Thank you to our partner in this series, the Colorado School of Public Health, for helping us bring all these great episodes to you and help us put together today's episode. For those of you who are familiar with our series and have been counting, today is episode number 32. So if you missed any of those previous episodes, we have all of them available. If you're ever interested in going back and checking them out, we have them on the Institute's YouTube channel. But today we're going to be talking about a very big topic. We're going to be talking about COVID-19's impact on schools and our youth. School is obviously back in session, but what does that look like? And what are some of the policies currently in place? And how have students fared in the past year and a half? We're going to be unpacking some of those big questions, as well as looking at some data on current infection and vaccination rates in our younger generation. So this is a really big topic. We're going to try to cover a ton of ground today. So stick with us. We're here for the full hour. But I am really excited because I have two really great speakers and experts joining me today to help unpack some of this. We have Rico Munn and we have Dr. Sean O'Leary. So let me take a quick moment and just introduce our guests. Rico Munn serves as a 16th Superintendent of Aurora Public Schools, as well as currently serving on the Colorado Vaccine Equity Task Force. Prior to joining Aurora Public Schools, also known as APS, Rico served in a variety of leadership roles here in Colorado, both in the legal and business communities, including he served as on the Board of Governors for Colorado State University System, the Colorado State Board of Education, as well as serving as Executive Director of the Colorado Department of Higher Education about 10 years ago. Rico has also been a successful attorney and practiced commercial litigation with a national law firm for over a decade, and he's very active in our local metro area's nonprofit community. Our other guest joining us today is Dr. Sean O'Leary, who is a professor of pediatrics at the University of Colorado School of Medicine and Children's Hospital, Colorado. He's a pediatric infectious disease specialist and the director of the Colorado Children's Outcomes Network. He has more than 160 peer-reviewed publications. That's pretty impressive. And his research has focused on prevention of vaccine-preventable diseases by understanding the clinical, attitudinal, and infrastructural barriers to vaccination, as well as developing and testing intervention to address those barriers. Dr. O'Leary is a member of the American Academy of Pediatrics, the Council on School Health, as well as serving as the vice chair on the Committee of Infectious Diseases, among many other leadership positions. So I will say we are in really great hands today. I'm going to stop talking and turn this over to both of our speakers who will have a little bit of a presentation to kind of set today's conversation, and then we'll get into Q&A later in the latter half of this hour. So if you're joining us here on Zoom, or if you're on our Facebook or Zoom channels, we want to see and hear questions from you that I can take to our guests during Q&A. So just go ahead and open that chat feature or use the comment feature, depending on where you're watching from, and type in your questions, and I'll try to get those all worked into our discussion later. I will give the caveat that I apologize in advance. We often do not get to all your questions, but we'll try to incorporate as many of those as possible. Okay, so with that, let me stop talking and have Sean step up here and give us the mic and give a little presentation to help set the stage. Good afternoon, Sean. Thanks for joining us.
Thank you for the introduction, Kristen, and let me make sure we get this working here. All right. Are you seeing my, well, no, it's blank there. Are you seeing my screen?
Looks great.
Perfect. All right. So I am just going to go right through here. A lot to cover today, and we want to leave a lot of time for Q&A. So just to dive right in, it's been a tough year. So just to summarize the 2020-21 school year and some of the things we saw and some of the things that we learned, you know, one thing that was very clear is that children have suffered greatly in this pandemic. We saw a really severe exacerbation of an already existing mental health crisis in children here in the US. I can't tell you how many of my colleagues in primary care have told me how their schedules are just overflowing with children in need of mental health intervention. Another thing we saw that was, you know, just an ongoing tragedy is that the existing inequities that we see in education have worsened, and that's been especially true for our most vulnerable children, and this was seen across the US. And then moving into some of the lessons that we learned about COVID and the pandemic, one of the things that was very clear early on in the pandemic, and that continues to be true, is that school transmission really reflects community transmission, but it does not drive it. So with many respiratory viruses, the epidemics start in schools, influenza being an obvious example. It's the opposite with COVID-19 in children. Usually transmission in schools, in fact, was less than what we would see in the surrounding communities. And then the other thing that we saw over and over again throughout the pandemic across the US is that layered mitigation measures were generally successful at keeping children in school when schools were open to in-person learning, even in times of high community transmission. So with that background in mind, what I'm going to cover briefly today is just some of the recent epidemiology of COVID-19 in children in schools. I'm going to talk a little bit about the impact of mitigation measures and then talk about vaccines and vaccinations. So just to start with the pediatric cases. So the American Academy of Pediatrics has been tracking pediatric cases throughout the pandemic using a combination of data sources, including publicly available state health department data and Children's Hospital Association data. And what we're seeing lately is that children are being infected more than ever throughout this entire pandemic. And you see I have in parentheses, it's not primarily because of return to school. Much of this recent surge in children happened well before children returned to school. And it's really a result of the really highly contagious nature of the Delta variant, combined with a relaxation of a lot of the mitigation measures that we saw work throughout the pandemic. The other thing I want to point out here is that this is happening with great variation across geography. So children are being infected and hospitalized most in places with low vaccination rates and minimal mitigation measures in place. And you can see that visually here, also showing the AAP data. Case rates are cases are much higher in the South than other parts of the US. And just to show you trends in hospitalization rates, we're now seeing, this is 5 to 11-year-old children not eligible for vaccination. These are national data from CDC showing that we are now having the highest rate of hospitalization that we've seen in the entire pandemic for this population of children. And then I want to just point one thing out here. At least 500 children have died of COVID-19. Again, this is American Academy of Pediatrics data, and these are incomplete data. But that may seem like a small number relative to the 670,000+ adults that we've seen die of COVID-19 in the US. But the thing I want to point out here is that pediatric death, fortunately, is a very rare outcome, and it's always a real tragedy. And what I want to sort of bring that home here, showing you these are the top 10 causes of pediatric death. So these are CDC data that I'm showing here, and by just about any measure, COVID-19 falls squarely in the top 10 causes of pediatric death. So it is absolutely incorrect to say that COVID-19 is a benign disease in children. Okay, so moving into schools specifically and some epidemiology. So these are two recent headlines, first from the Denver Post and the second from Colorado Public Radio, basically showing the impact of masks and what we're seeing here in Colorado. And this is also true across the country. And I'm going to show you some data on that. So this is a slide from Georgia showing the 7-day case rate per 100,000 in children 5 to 14. And the shaded area there represents when schools were in session. The line on the bottom are in school districts, the case rate in children of COVID-19 in school districts where masks were required in schools, compared to the line up above where masks were not required. And you can see sort of a dramatic difference in case rates. The same was true in Indiana and here in Colorado. So this is showing school districts that reopened August 16th to 19th that required masks compared to those that didn't. And then this is even more striking, districts opening August 23rd through 26th. So masks work. And just to point out, this is what we kind of affectionately refer to as the Swiss cheese slide. Layered mitigation measures work for prevention of COVID-19 in schools. No one single thing is going to stop COVID, but if you have multiple things in place, including things like masks, vaccinations, we're going to really do a good job of keeping kids successfully in school. Okay, moving into vaccines and vaccinations. I'm going to talk a little bit about doses administered in the US and Colorado. So the first thing I want to point out is we've given a lot of doses of vaccines, but we need to give a lot more. So it really is impressive that we've administered over 800 million doses of vaccines in the US already, or sorry, 300 million doses of vaccines in the US already, but we still have a long way to go. And you've seen that it's tailed off. We still need to work really hard to bring those rates up. And speaking about kids specifically here, these are CDC data showing the percent of children who have received COVID-19. So you can see the 12 to 15-year-olds, roughly 54% have received one dose, 16 and 17-year-olds, 62%. So, that seems like a pretty good number, but we can do a lot better. Colorado numbers are similar, I will just tell you. Now, moving specifically into Colorado, this represents actually the whole eligible population, so not just children specifically, but I want to point out that the adult vaccination coverage has a great impact on children. And so here what we see is wide geographic variation. So you'll see the darker colors represent higher levels of vaccination coverage and the lighter colors represent lower. And a lot of our large metro counties have very high coverage rates, but some of our other large counties have significantly lower vaccination rates. And so the implication here is that because community transmission drives pediatric case rates, the impact of vaccination on cases of COVID-19 in schools is going to be quite high in the counties with high rates, but lower in the counties with low rates. And just to drive that point home regarding specifically vaccination of children, this is a slide from our state health department. Higher vaccination coverage in teens, so this is looking specifically at 12 to 17-year-olds, means fewer cases in school. So over on the y-axis here, you can see the 14-day case rate per 100,000 among children 12 to 17 years old, compared to the share of the population that's fully immunized in that age group. And you can see a strong linear relationship here. The counties that have higher coverage rates in that age group have significantly lower case rates. All right, so now let's talk briefly about pediatric vaccines for kids under 12. So just to walk you through this, these are the 3 vaccines that are currently authorized for use in the US. We're not going to talk about the Janssen vaccine for children because that's quite a ways off, if ever, for kids. But for the Pfizer and Moderna, I'm going to walk you through this slide. So for Pfizer, many of you are probably aware that it's fully licensed now for ages 16 and up, and it's authorized for children 12 to 15 years of age. For the younger kids, these data actually were just submitted by Pfizer to the FDA this week. And there is an expectation that we may have authorization as soon as a few weeks from now for children 5 to 11 years old. And there will be quite a few CDC meetings to discuss this in the coming weeks. But we may see vaccines, our children 5 to 11 eligible for vaccines as soon as mid to late October. For the younger children, the latest I have heard is that we may see a submission from Pfizer to the FDA for the 2 to 4-year-olds sometime in November, with potentially FDA action on that within the following weeks. There is some uncertainty around that timeline though. And then for kids under 2, probably a little bit after that. And then I'll just summarize Moderna to say that the 12 to 17-year-olds, we may be seeing a submission for that fairly soon. And then for the other children, they're probably a month or 2 behind Pfizer on that timeline. All right. Now I want to briefly talk a little bit about some of the attitudinal things that we've seen around vaccines. So Kaiser Family Foundation has been doing these nice surveys throughout the pandemic about attitudes about COVID in general, but also the vaccine specifically. And there are a few highlights I wanted to point out here. The first is that essentially what we're going to see in these coming weeks after assuming these vaccines are authorized for the younger kids, is that the uptake is probably going to be fairly similar to what we've seen with the 12 and older. We'll probably roughly see about 1/3 of parents who are very eager to get their children vaccinated as soon as possible. And then we're going to have a fairly large proportion of parents who take a wait and see approach, who then get their children vaccinated in the subsequent months. And then there may still be some parents who are really holding out, not wanting to get their kids vaccinated. And this very much parallels essentially what parents do for themselves, they often will do for their kids regarding these COVID-19 vaccines. The other thing I want to point out is that school encouragement can make a difference. So what this slide is showing is the parents responding to the question, did your school encourage COVID-19 vaccination or provide information about COVID-19 vaccination? And you can see down here, a very striking difference between parents who said that their child is vaccinated compared to those that didn't. If the school encouraged vaccination, actually a lot more parents said their child was vaccinated, similar if they provided information about vaccination. And then finally, the thing I want to point out from these surveys from the Kaiser Family Foundation is that the safety is parents' top concern. But I want to point out that this is really actually based on a mistaken assumption. And I think this speaks a little bit to the success that a lot of the misinformation and disinformation campaigns that have been going on throughout this pandemic, even before the vaccinations became available, have been pretty successful. So you'll see that the top concern is that not enough is known about the long-term effects of the COVID-19 vaccine in children. And the thing I want to point out here is not to say that there are never side effects from vaccines. I think we're all aware that we get short-term side effects like fever and soreness and things like that, but there can rarely be significant side effects. And examples of that would be what we've seen with potential severe allergic reaction happening roughly between 2 and 5 in a million doses. And then even in children, adolescents and young adults, this issue of myocarditis on the order of maybe 20 or 30 per million doses. So rare side effects that are identified. But the point I want to make here is that those types of rare side effects happen in the days to maybe weeks after vaccination. They don't happen several months after vaccination. And in fact, there's really no precedent with other vaccines that we give to children and adults of side effects that appear months or years down the road. So this number one concern about long-term effects is really based on a mistaken assumption. That actually doesn't really happen with vaccines. Okay, now I want to finish up just making one final point about routine vaccines. So routine vaccinations, so we're talking about all the things that we vaccinate our children for and that are required to attend school. They fell off dramatically during the pandemic. And I'm using the MMR vaccine as an example here because measles is essentially the most contagious disease known to humankind. You need very high vaccination coverage to keep it from spreading. You're probably aware of a lot of the outbreaks we saw around the country in 2019. And we saw a dramatic drop. You can see at the bottom just percentages of drop in 2 different periods over the pandemic of measles containing doses in the US, in several states across the US. This is true across the country. I'm just using this one example of this one study to illustrate the point. And we have not caught back up. And this is just for those of you who like to see it in a different way. This is just showing the dramatic drop we saw % change compared to the prior year in doses of measles containing vaccines. So we actually are at significant risk at this point for vaccine preventable disease outbreaks for diseases that are frankly more severe in children than COVID-19. So just a reminder that it's going to be really important to get our kids caught up on the routine vaccines as we're thinking about the school year. So just to conclude, the major points I want to make is that children have suffered greatly from the pandemic and educational inequities have worsened. Safe in-person learning should be a top priority for all communities. Preventing COVID-19 in children matters. Vaccination of children against COVID-19 is one of several mitigation measures that can assure children can attend school safely. And another big point I want to make is that even after vaccines are approved for younger children, the single best thing that can be done to protect children in schools is to achieve high vaccination coverage across the population. And then finally, we mustn't forget about catching children up on school-required vaccines. And I will finish there. I've got a list of references here that will be available if you all are interested in reading further. And I will stop sharing my screen and pass it off back to Kristen.
Thank you. Yeah, thank you. Let me ask you just a quick clarification question before we move on to Rico. Sean, one of our guests had noted earlier in your slides, I think it was when you're showing the top deaths in children and adolescents, that the listed flu and influenza and not just COVID. And they were curious about the COVID breakout from that. The block within COVID within.
Yeah, so I should have been clearer. So that slide was from 2019. Those were data from 2019, and that representing a sort of a typical year. And so the number of childhood deaths from flu and flu-related illness varies year to year, but it's roughly between 200 and 500, depending on whose estimates you use. So COVID-19 actually is more, what we've seen is it is probably more severe in children than even influenza. But as I mentioned, not nearly as severe as other vaccine preventable diseases, for example, measles being an obvious example.
Great, thank you for that. All right, we'll come back. There's a lot to talk about from that presentation. Thank you. Okay, I'd like to welcome Rico to come on and give us a little overview of what's happening in your school system.
Sure, thanks, Kristen, and let's see if I can navigate the technology here to share my screen.
Looks great.
All right, you can see and hear the. All right. Well, good afternoon, everyone, and thank you to everyone for inviting me and a chance to talk about our experience here in the Aurora Public Schools. Let me state what I hope is the obvious, that our experience in APS is not necessarily the experience of all 178 school districts, but we think it can provide some insight into how others are experiencing the COVID-19 pandemic and in the work that we've done over the last nearly 2 years. Is that?
Is an illness caused by a virus that can spread from person to
You got some CDC announcements coming on?
I think that's Siri telling me about the coronavirus. Sorry about that. By way of situating you with the Aurora Public Schools, we are the 5th largest district in the state. We serve about 40,000 kids. We come from 130 countries, speak 160 languages, and our free and reduced lunch numbers are around 70%. So we have a very dynamic and diverse district that we serve. But from the standpoint of how we experienced COVID-19, and let's see if I can advance the slides here. You all know kind of the timeline roughly in Colorado, where we started to see the first diagnosed cases of COVID around early March. It happened very quickly across the state, where we were starting spring break at the end of that week of March 12th. We thought we'd be gone for a week or two. We ended up being gone for a significantly longer period of time. As that became real, we started a meal distribution process in our community. You heard about how economically impacted this community is. We started handing out meals at 16 distribution sites on March 17th. And by the end of March, it was clear that we were going to be going into some kind of remote learning environment for some period of time. Just to break down some of that detail for you, we started providing meals at 16 sites all across the Aurora area. Through last July, we served more than 8 million meals to our community, with a significant portion of those being to hungry adults as well. No questions asked, whoever walked up. We fed this community for a significant period of time throughout that pandemic. And I say that because we're very proud of the work of our essential workers, our security, our custodians, our nutrition services, who were out there 5 days a week, sometimes 6 days a week throughout the height of the pandemic, just serving this community and serving meals. And thanks to the many donors who helped make that happen as well. We talked about our remote learning transition. We were not a district that was one-to-one prior to the pandemic. On March 12th, we did not have devices in kids' hands. Within 2 weeks, we had handed out nearly 20,000 devices to kids to start preparing them for the remote learning environment. We also then had to think about how we partnered with folks like Comcast and others to make sure that we could bridge that digital divide and really start setting up an infrastructure for remote learning. We also were fortunate to be in the position to really support kids in their mental health needs. We saw a significant need and continue to see that. We had resources on hand that allowed us to have a number of mental health professionals, and working also in partnership with Aurora Mental Health, we were able to stay connected to kids through those devices to support their needs. We have surveyed our kids to try and get an understanding of what their needs were. We were very proud of the fact that our kids, in large numbers, said they knew who to connect to. They had somebody to connect to if they had those needs. But the need is significant, and it's ongoing as we see as kids come back in person fully this year. But as we experience remote learning, we operated on a number of platforms. In APS, we were fully remote for the first quarter of the 2021 school year, with a few exceptions for some groups of students. Then come second semester, we transitioned to more of a hybrid, where we were 2 days on, 2 days off for some kids. It varied across different levels and different situations, but we were able to get kids back in the building on a consistent basis come January and February of 21. As we came back into this school year, we have about 98% of our kids who are back in the building. We have some portion of kids who opted to stay remote. We hope that as more vaccine adoption comes online, all of our kids come back. But that's still a process that is very difficult this year as we figure out how to best serve kids' needs. So we've had to ramp up our work around the IT department, obviously, thousands of calls coming in from multiple languages. I spoke to you about some of the language issues. And so that's been a significant challenge faced by all of our folks and all of our colleagues across the metro area of how to respond to those needs for our students and families. When we think about, however, those needs and supporting that, we were fortunate that we could kind of fall back on some of the structures that we had in place. A couple of years ago, we rolled out and launched a comprehensive health and safety framework that we called Aps Cares. As you can see, CARES is an acronym for how we thought about our supports and our systems and our resources. And we really relied upon that as a way of thinking about how we work with our families and supported them. We really had to think very deeply about our communication structures and how we stayed in contact with kids who we weren't seeing on a regular basis. They weren't coming in the building. We weren't handing out flyers to families. We weren't having in-person back to school nights, those kinds of things. So we would send regular emails and phone calls in significant languages. We started using a new texting app that allows kind of instantaneous translation to all of our families in different languages to stay connected with them, to communicate what was happening, what resources were available, and how we could best support them and also get that information back from them. We set up new communication structures. We had a new website. We used new social media platforms. And we did just a variety of things to stay in contact with our families to make sure that as a trusted resource that they could come to us and understand what was happening. And that really followed what we think were some of the best benchmarks for crisis management that our team put in place right away, making sure that we had clear lines of communication, that we had a very clear and strong command and control structure, and that we provided as much transparency as possible to our community and what we knew, what we didn't know, what our next steps would be and why that was. And that was particularly important around the public health measures. We told our community and made our commitment to our community of two key things. One, that they would not get health advice from me. I'm a lawyer, not a doctor. They were not going to get health advice from me around what I believe was best. And then secondly, we were very clear that our single source of truth, our North Star, was going to be our local public health partner, Tri-County Health. If you think back to the beginning of the pandemic, there was lots of public health voices out there, the WHO, the CDC, that at the time was seen as fairly politicized and questionable. You had pronouncements from the FDA, from AAP, from every alphabet. And we wanted to make clear to our community that we would have a very clear, consistent voice. So if something came out from the CDC, something came out from the AAP, we said we don't care. Until we consult and talk with Tri-County, we will not move and we will not respond to all those different voices and that different stuff coming out. So we've been very clear on that and stayed very true to that with our community as we've tried to implement things so we can always track back and be transparent with our community around that work. Just to give you a sense of where APS has been situated in the COVID discussion, we were the first school district in the state to provide for free testing for all of our staff. We were the first district in the state to put in place a vaccine mandate for our staff. We announced that back in May. We were the first district in the state to require testing or masking for all of our athletes. And I don't say that to position us as in some leadership role, but for you to understand how we have responded and reacted, and to inform you as we get into the kind of the Q&A session as to kind of our experience in kind of leading in some of those conversations. We've tried to be very thoughtful in our approach, and that includes just this last June, we put out a document which really talked about our lessons learned, where we gathered all of the feedback that we had been gathering throughout the year and talked about here are some of the top lessons that we have learned throughout the pandemic. First and foremost, we know that equity had to be at the center of any response that we had and put out. When you talk about the diversity that we serve, the different languages, the different demographics, we had to really think about how we continue to make sure that we provided equitable response in all the work that we did. I'm incredibly proud, and we're incredibly proud of how nimble we were, how quickly we were able to move everything to a remote environment, to in and out of different settings. It's not been easy, but we have found ways to really adapt as a large system. We know that our engagement, our communication is key. It's always can be better. And we were better served when we could provide direct information from our public health partner, from Tri-County Health and others, as to what was happening and what next steps were, and trying to facilitate that for our community. And we always want to make sure that we understand, Maslow's hierarchy, what the basic needs of our students and staff are. We can't always provide those and serve those, but we can be a conduit and a partner. So when vaccines became available, we quickly partnered with 5 or 6 local providers to get them lists of our staff who were eligible and appropriate for vaccines, so we could quickly filter through that and get that to folks. And then some of the other lessons learned is that we know that innovation is important, but we also should base it upon our existing structures and experience, as I pointed out earlier. And we really learned that the relationships that we have with our students and families, the informal ones can be as important as the formal ones. We missed seeing our kids. We missed having them in person, connecting with them, knowing what their needs and their concerns were. And then it was really a lesson to see how important it was to continually invest in our infrastructure. The fact that APS, 100% of our buildings were air conditioned. We had, for the most part, our buildings had HVAC systems that were newer. All those long-term investments that we had made over time really paid off in that crisis situation. We were very glad to see that. So it's been a fascinating experience on one hand. It's been a traumatic experience on the other. We are still in the thick of it as we address all of our kids and staff coming back who are still very traumatized, who are still very on edge around a lot of these issues. And as we continue to navigate changing circumstances and changing public health rules, we continue to try and rely upon the best science and evidence that we can, and work with partners like Tri-County to get that information. So with that, Kristen, I will turn it back to you and figure out how to release my screen here.
Thank you, Rico. Yeah, and you and Sean, let's bring you both back on. We'll have about half an hour here for some questions. We've got some from the audience. But I want to, just to make sure we're kind of setting the stage a little bit here too, because Rico, you mentioned this, but then Sean, you had that Swiss cheese analogy, right? About a layered mitigation measures and how, we have this block of cheese and there's different measures that we can have in place. So maybe I'll start with Sean, and then Rico, you can make it into a practical sense about what you all are doing in the Aurora Public School. But, is there some sort of gold standard that schools should be aiming for that kind of multi-layered mitigation approach? Sean, why don't you start and tell me if there is, and then Rico, you make it very practical what you guys can do.
Sure. I mean, I want to emphasize the point Rico made about, working with your local public health department. I think there were a lot of confusing messages throughout the pandemic, and really, we're fortunate here to have a lot of great local public health departments. Tri-County being a fantastic example, and they've been a good public health department for many decades and really stepped up in this pandemic. I think the challenge comes when your local public health, and basically in answer to that question, the simple answer is you work with your local public health, and what do they say matters. The challenge comes in some of the districts where they essentially ignore the science, and the local public health departments don't have the resources or the authority that say Tri-County does. And that's where some of these national guidelines become more helpful to help guide the districts with what they're going to do. Now, in terms of what works, I mean, I emphasize masking in my talk. But there are a lot of other things. Of course, vaccination, that's probably one of the single most important things, as I also mentioned. But there are others. I mean, I think, early in the pandemic, there was a lot of hullabaloo about, cleaning. And that's probably not quite as important, scrubbing every doorway, because it also comes at a cost, right? You're devoting personnel that have other things that they need to be doing when you may not even be fully staffed. So some of the things you really have to make decisions about, and I think Rico is probably much better qualified to answer that question, because you really have to prioritize what are you able to do with the resources you have.
And speaking for our part, if you look at the CDC's latest kind of back to school guidance, which essentially got adopted by CDPHE, and then our local health department. They identified 9 mitigation strategies in that. And that's really the framework that we walked into this school year trying to think about. And as we looked at that list of 9, and I won't be able to list them off exactly, but there were 7 of those that did not impact the educational environment, and 2 that did. And so we really took the mindset of our first responsibility is to do everything we can that doesn't impact the educational environment, and to go to the other 2 only if we have to. And if we have to, so be it, we have to, but to try and avoid that if possible. And so we really try to maximize those 7 layers, the top of that being vaccinating our adults and pushing vaccines where appropriate with our student athletes who are engaged in high-risk behaviors, meaning athletics as the high risk that's identified by the public health authorities. And so we really did our best to maximize those at the beginning of the school year. As we got into the school year, public health guidance shifted and said really that those 7 were not enough. We needed to utilize one of the other 2 as well, which were either masking or quarantines essentially. And so that became then one of the mandates in Tri-County was to implement masking. So I think if you look across the landscape of public education, everyone is trying their best to maximize those things that don't impact education first, because obviously we're here to try and educate kids. But if we have to go to the next step, we all will if we have to.
You both brought up vaccines. So we're just going to go there. Sean, you had showed some of the lower vaccination rates in that 12 to 18-year-old population, showing some concerns over the current safety is what people have expressed about why they haven't gotten their children vaccinated. So I'm curious about ideas and thoughts on incentives, saying apparently it seems like the school can have a big influence on how people choose whether or not to get their child vaccinated. So I'd be interested in your thoughts on incentives, and perhaps we can segue into the concept of would schools, or do schools, certain schools, I know universities do here in the state, mandate the vaccine, and when would that look like, and what would that look like? So one of you can start. Sean, I see you nodding. You want to take the first stab, and Rico?
Sure. Yeah, this is kind of where I live. One of the things, kind of the elephant in the room that we haven't really mentioned is the tragedy of the sort of the partisan divide that has happened in this with this pandemic since really the beginning in the U.S. and it didn't have to be that way, but it is, and that's where we are today. And it's really translated into vaccination status. I didn't show you slides on it, but there's a dramatic difference in vaccination uptake simply based on party affiliation, and that's true for pediatrics as well. And that is a very difficult bridge to cross once it's become part of a person's worldview, because for many of these folks, it's part of their sort of worldview to be not believe in the pandemic, to dismiss the vaccines as a government conspiracy, whatever. There are lots of different things, and there's a lot of behavioral science behind how it's difficult to move folks that have gotten a vaccine attitude or other health behavior attitudes sort of ingrained into their overall worldview. So that is a real challenge. In terms of incentives, there are a lot of things we know about incentives for routine vaccination that I think also translate to COVID-19 vaccines. And one of the things, of course, that's a very hot topic right now is requirements. And I think, that is one very effective strategy at increasing vaccination coverage, is having vaccine requirements. That we've had vaccine requirements for schools for many, many decades, and that has led to very high vaccination coverage in our children and in our schools, and essentially the elimination of all of these deadly diseases. So we don't even see them anymore, because we have had these school vaccination requirements in place for many, many decades. So in terms of requiring the vaccine in schools for kids, as you may be aware, there are some districts that have already made that decision. So, the LA being the largest district. I suspect that some districts are probably not far behind in making that decision. Now, what some districts have said is we're not going to make that decision until there is a full BLA, but biologics license application approval from the FDA, as we've seen with the 16 and older group. And that's actually what we saw with a lot of the federal requirements, United Airlines being an example of a large employer that made that decision around the time that FDA granted full licensure to the Pfizer vaccine. So we may see that happen when that happens for children, because really the reason that school vaccination requirements are in place are, one, to protect the children themselves from these deadly diseases, and two, to protect the community as well. And so there's really nothing different about COVID-19 in that equation, other than the fact that right now for kids, the vaccines are authorized under an EUA.
And I don't know that I can really speak to incentives. I mean, I do think that's more of a behavioral science question. You know, we, as far as we've got a vaccine mandate for our staff, and it's, we have simply said that's a requirement for employment in the Aurora Public Schools. And so it's, you know, in our structure, like having the appropriate degree, this is what you need. And so we've simply moved into that framework. As for students, I think it's an open question in Colorado, or at least an unclear question, as to whether or not school districts have the authority to create that mandate for students. And so I expect that you won't see any districts in Colorado do that kind of mandate until there is a little more clarity from state officials around what that process would look like, or who really owns that authority.
Yeah, and so Board of Health in general is the group in Colorado that makes the vaccination requirements for Colorado, and they advise the governor and CDPHE. So it would probably, if that were to happen in Colorado, that's probably the mechanism by which it would happen.
So this, I want to pick up on this thread a little bit too, because Rico mentioned it earlier about choosing who to listen to and who to trust and who to get the scientific information from, right? And Rico, I think being really transparent about, like, you know, there's a lot of different institutions and bodies, and who are we going to turn to, and being clear of who you were following and turning to. I like that. I like that you shared that decision-making part for you. But there is that bigger question, right? And Sean, you alluded to that about the politicization, right? And we talk a lot about trust in medicine, right? And there's some legacy there. This is a whole topic, believe me. But I'm curious, when you all have been thinking about trust lately, trust in medicine and trust in institutions, what's something that you think others should know about that, right? Like, we see diminishing trust, and we want to try to, you know, keep trust and build trust where there hasn't been trust there before. So where have you seen some opportunities, whether that's in your own work or through the own lens, of where we could start to build trust? Not an easy question, so I'll let both of you tackle it if you can.
I think this obviously has been hopefully an opportunity to do that. I think for us, it's been key, again, around transparency and consistency, where we would talk to our community around what we knew, what we didn't know, and how we would respond, and then to be consistent in how we did things and why we did things. Even if people didn't like the decision, hopefully they saw that consistent thread and the why of how we did it, so they could count on what the next decision would be based upon that same kind of pattern, that same kind of data. That's why it's been so important for us to have that very clear North Star, and why we have consistently said, that's nice that these other folks say this, we are not going to pay attention. And I think that's maddening to some of the public health people who say, well, you know, this authority said this authority said that, why aren't they reacting? Because we have to maintain and build trust with our community around how we are responding and what the mechanisms for responding will be.
And just to speak a little more broadly on that topic, you know, trust in science has been kind of eroding for the last several decades. And, you know, it's a real problem, and it's a real challenge. And I think, you know, one of the things, you know, part of it is, you know, continuing to educate our children and youth on science and the scientific method. I think in my own world of working with pediatricians and family docs on communicating about vaccines, one of the things I try to emphasize is really educating the families that they work with on finding good trusted sources of information, and really trying to do a pre-bunking strategy. So you don't have to debunk myths once they're already there, because that's a very difficult prospect. Once somebody gets a hold of some kind of a myth, it's really hard to get that out of their minds. So trying to pre-bunk with, this is what you're going to see on the internet if you go look for this. These are the methods that people are going to use to try and convince you that vaccines are bad, or whatever the health topic happens to be, and really pointing them towards trusted sources of information, and really avoiding as much as possible social media, et cetera, for you getting their health information, because there's so much misinformation and disinformation that is being spread on those channels. So trying to really get people to understand, where do you get your information, and making sure that those are reliable sources.
Thank you both. The vaccine mandate generated a few questions that I want to come back to from our audience. So one was about the idea of religious and medical exemptions being allowed for vaccine mandates. Should there be, when it comes to COVID, and if we get to that point of having a vaccine mandate for schools, and is it allowed for the MMR?
Right, so complicated question. But what I will tell you, let me start with the fact that all the world's major religions strongly support vaccination because it saves lives. And there have been a lot of major statements made by leaders of different religions, including the Pope, basically saying that getting vaccinated is actually an act of love. You're not only protecting yourself, but you're protecting your neighbor. So a lot of the reasons that I'm hearing for people asking for religious exemptions are actually based on misinformation. So that's point number one. Now, regarding whether or not they will or should be allowed, it's going to depend on the setting. Some settings are really not accepting religious exemptions, some healthcare settings, for example, or they're being very, very strict on those that are granted. The federal law on the issue is basically, I think it comes from the Equal Opportunity Employment Commission, is basically that religious exemptions should be allowed. Medical exemptions should always be allowed. Religious exemptions should be allowed if it does not, I don't remember the exact legal language, but basically if there's not undue burden on the workplace. And so for some healthcare settings, for example, they may consider that undue burden because you could be transmitting COVID-19 to your colleagues, to your patients, and causing harm. And so in some settings, there may not be religious exemptions granted. Regarding school and children, it varies very much based on the state. Currently, Colorado has a process for granting non-medical exemptions, and that includes religious exemptions. And so that's sort of easily available by just looking at the state health department website, what the policy is there. So yes, those are available for routine vaccines. We like to make sure those stay fairly rare, though, because we do need to maintain high vaccination coverage.
Thank you. Rico, do you want to add anything onto that? Okay. Maybe Rico, you could respond to this question regarding the vaccine mandate for staff. When there is challenges, I'm guessing, in just sheer numbers of personnel and shortages. Did you have problems with the vaccine mandate impacting the number of staff that you have?
Yeah, I think it's a significant thing to think about. I mean, as I said, we were the first in the state, and at this point, there's only, I think, 3 districts in the state that have that kind of mandate. I think there's going to be a 4th by the end of the day, is my understanding. The reason we announced ours in May, we said we will have a mandate as soon as the FDA approves one, was so that we gave people time and opportunity to make professional decisions around whether or not that was something that aligned with their beliefs or their needs. And then having given them, roughly 5 months of lead time on the back end, we're going to be a little less understanding of people saying, well, I don't agree, right? You had some time to figure this out. And so we've had a significantly high level of uptake. We've had a pretty low percentage of people asking for exemptions. We do provide for religious and medical exemptions. And we believe that, for those folks who we do then have to think about alternative, employment arrangements, that we've done our best to provide, appropriate notice and appropriate staffing.
Thank you.
The one thing I'll add to that is, in healthcare settings, we've had requirements for vaccinations for many years for certain types, and then flu vaccinations over the last several years. And there was a lot of concern that they would be, once health hospitals adopted a flu vaccination requirement, they'd lose, a large percentage. That really didn't end up happening. And, a handful of people might quit, but most of them go ahead and get vaccinated. And so now healthcare settings have very high flu vaccination coverage and less transmission of influenza. The same is happening, I think, to a lesser extent with COVID-19 vaccine requirements that we're seeing so far. Certainly they're making headlines, the people that are protesting those, but at the end of the day, it's a relatively small number of people that are actually leaving their jobs rather than getting vaccinated.
Let's pivot a little bit to talking about mental health. We know this is a serious concern. I think, as the pandemic was unfolding, it was talked a lot about, but there's a lot that was unknown about the true impact on the mental health of our youth. And I'm curious, I've even heard this term, and I'm not acknowledging it's an accurate term, but the idea of a lost generation, right? And these kind of long ongoing residual impacts of what happened in the past 18 months. So I'm curious from both of you, about the mental health aspect, whether reflections on that concept of a generation struggling and being lost or left behind, or just how our youth are faring, and what maybe could we have done better? Do we have any reflections on that?
Rico, do you want to start with this one?
Sure.
These aren't easy, I know.
Yeah. What we tried to do, as you saw, some reflection about our lessons learned, right? What do we learn throughout this pandemic around how to better serve our community and better serve our youth? I think what we know about that is what we knew before, is that we need significantly more mental health supports, mental health professionals working in our communities and working with our kids. And we have a high amount of need across the state, across the country for that, and not enough resources or supports in place for those everyday challenges, but also the heightened level of challenge that we're at. Across the country, what you are seeing is significantly and dramatically increased negative student behaviors. That's happening everywhere across the country. It is very challenging and very, very concerning and scary, quite frankly, what you're seeing across the country with some of those student behaviors. And that is kind of across the board, right? We have second graders right now who effectively didn't have a full kindergarten or first grade experience. And so in many ways, they're still kindergartners. And that is incredibly challenging from a behavioral standpoint, but then also from an instructional standpoint. And that's the same as you think through different grades, particularly at those transition grades. We have 10th graders who didn't really experience some of that transition through their freshman year, right? And some of those transitions in high school. And that can be very challenging and difficult for a whole host of reasons. And then we have staff across the country who are not as regulated as we would like them to be in their emotions and their behavior. And when you add to that across the country, there is a real crisis in staffing in every industry, but also in education, when it comes to everything from who we have in the buildings, who we have driving our buses, who we have as subs. All those things are still at a crisis level. This is not past us, and we're still experiencing that on a regular basis. At the same time that the need for our students has increased, right? The learning loss is significant. The learning loss is real. And it is something that heightened need is happening at the same time that we are seeing resources diminish to try and respond to that. Not the dollar resources. What the federal government has done through ARP and through those other mechanisms is incredibly important. but there's still significant gaps in how we have the human bodies and the professional skills around those resources.
Yeah, the only thing I would add to that is that, you know, it's not like the pandemic, you know, everything was perfect before the pandemic. As I mentioned, you know, there's longstanding inequities in education in the US, and you know, mental health issues disproportionately affect certain communities, and you know, those issues are longstanding and are not going to be solved overnight. And the pandemic only exacerbated a lot of those issues rather than creating them. And so I think, you know, going forward as a society, I really, you know, hope that we can really start to reverse some of those trends that we had seen even before the pandemic started, because these issues are longstanding. I mean, starting with the way we fund public education, frankly. I'll stop there.
Yeah. These are big questions. They're all hour topic discussions on their own. So thank you for entertaining them. Sean, I want to ask you just to provide a quick response for a question in chat to clarify, and then I'm going to come back to both of you for kind of a closing thought. So Sean, one of our guests wanted to know why children were not vaccinated before other groups.
Yeah, you know, it's an interesting question. I think the primary reason kids weren't vaccinated is because of the severity of the disease in the different age groups. So it's most severe in the elderly, and so that was, you know, the primary focus first, and then of course healthcare workers because of and other frontline workers, you know, sort of in the next group. The reasons I would say that kids were not in the priority in the beginning are twofold. One, because the disease is, although it's incorrect to say it's benign, it is less severe in kids than it is in older adults. And then the second reason is that's basically how medicines, including vaccines, get approved in general. So for any medicine, including vaccines, you start testing it in healthy adults. And then you roll it out, you may roll it out to other populations of adults with chronic medical conditions, something like that, before you test them in children. Vaccines are held to a very high safety standard, really higher than any other medicine, because we're in general giving them to healthy people as a preventive strategy, as opposed to other medicines where we would tolerate side effects. And so in kids, we have to make sure that they're safe before we start even testing them in kids. It's safe in adults. So we saw that, then we tested them and started testing them in children. And so that's where we are now. The process for children in terms of getting vaccines approved is just by definition going to take longer than it does in adults. Now, a lot of us in the pediatric world wish it had happened a lot faster. And we in fact pressured the FDA, the American Academy of Pediatrics, has been lobbying throughout the pandemic to really try and get these trials sped up so that we could get vaccines into kids sooner.
Thank you. All righty, like I said, one final closing thought question, and we'll keep it short. It's October 1st. We've got 3 months left of this calendar year. I'm wondering, you know, where your current mood and thoughts are. You know, you could give me one word about your feeling for the next 3 months, and maybe a short why about what you're feeling for the next 3 months. I would love that. Give you a minute to think, and then the first person to nod their head gets to go first.
I think I'm hopeful. I think we've seen vaccinations start to pick up, and I think there are some models showing that we may be on a downward trajectory. And if we can maintain that downward trajectory as vaccinations pick up, I think we may be starting to see the beginning of the end of this pandemic over the next, I'd say, 6 to 9 months.
My word is cautious. Our systems in K-12 really are balancing on a razor's edge right now with the different stressors around the system. And we think, you know, a juvenile vaccine, ages 5 to 11, sooner rather than later, will be incredibly helpful. But if it gets held up, or if that gets put off for whatever appropriate reasons, then the stressors only get magnified.
Great. Thank you both. Hopeful, cautious, hopeful, optimism, something. I don't know. We can combine those two words.
I
Yeah, thank you. Thank you, Sean. Thank you, Rico, so much. I really appreciate your time and dedication to coming here, sharing with our audience, having a conversation with me. It's been lovely getting to know you both and have this opportunity. So thank you for joining us today.
Thank you.
And thank you to our audience. I really appreciate your time and attention. Nicole's probably dropped some links in there where you can catch up on the recording and make sure you're signed up for our mailing list and follow us on social media. I really appreciate you all joining us today. Hope you have a very nice weekend and that you stay very safe, stay very well, and definitely find those moments to take a little joy in your life. So thank you, take care, and until next time.